Good afternoon, everyone. I am Carrie. I'm from Johannesburg, South Africa. A portion of this research project formed my PhD, and my supervisors are Professor Ans Bayens, who's the head of clinical radiation in Ghent University, and Dr. Jeffrey Kotzen, who's the senior radiation oncologist at our institution. The authors declare that we have no financial interests. I'd like to give a quick overview. First of all, 85% of the world's cervical cancer patients are in developing countries. 87% of the world's mortality from cervical cancer is also in developing countries. The problem that we have is that the majority of research on protocol design for cervical cancer comes from developed countries. So we can't apply these protocols in South Africa. The reason being, sorry, I'm a bit nervous. We have in Africa 54 countries, of which 28 do not have access to radiation. Only 20 countries have access to brachytherapy. And those who do have radiation don't have sophisticated imaging technologies, so we rely on 2D planning, and we definitely don't have image-guided brachytherapy like the rest of the world. So we cannot apply the standard protocols in our country. I'm mentioning this because I'd like to highlight the reason we chose the hypothermia that we chose is because they proposed a method of monitoring the energy, the dose concept by monitoring the energy input rather than by monitoring the temperature. So this meant it was easier to integrate into the workflow in our situation. Okay. The rationale behind our study, it's the first hypothermia study in Africa in a resource-constrained setting. In HIV-positive patients, that's important because they're more radiosensitive than HIV-negative patients. And at the time we designed the trial, this was the first phase 3 study on this particular form of dosing concept. Okay. So I'm presenting preliminary results on the 3-year survival. Originally, we planned only to monitor for 2 years, but we got an ethics extension to monitor our patients for 5 years post-treatment. So I have some very early data, which I'd like to share with you today. Okay, the patients were clinically staged. They were not staged with any imaging techniques. This is very important. We were fortunate enough to get funding for PET-CT scans, which we could use only for tumor response. We did not change the staging based on this. Okay, stratum, we randomized the patients, and the stratum include HIV status, stage of disease, and age. Okay, as I said, HIV-positive patients were included. Hypothermia was given twice a week. Immediately before external beam radiation, we administered 50 grays external beam with 3 doses of 8 gray brachytherapy. We planned for 2 doses of cisplatin. I say planned because this wasn't always achieved in our patients. I'll explain just now why. About 50% of our patients are HIV positive, and about 15% of our patients did not receive any cisplatin. The reason being, we have about a 6-week waiting period from the time of enrollment to treatment, and during this time, a lot of patients developed renal dysfunction. Okay. So, we have 165 patients eligible for 2-year survival analysis. Of those patients, we could evaluate local disease control, and at 6 months, and we saw 38% versus 21% in the control group had local disease control. This was considered a failure if there was any disease in the pelvic radiation field. The reason we evaluated that and not only tumor response is because we administered radiation homogeneously to the entire pelvis. We used a 2D planning 4-field box technique. Okay. The interesting data, 2-year disease-free survival so far. We have significant results of 52% versus 34%. And then our 3-year disease-free survival is 58% versus 35%. This was very interesting. We had 54 patients in each arm who had extrapelvic disease, nodal disease on the pre-treatment scans. As I said, we didn't change the staging based on the scans. So We monitored them at 6 months post-treatment, and we saw 24% of patients had complete response of all the disease, including extrapelvic disease. This was quite surprising for us, and it occurred equally in HIV positive and negative patients in the hypothermia group, versus only 5.6% in the control group. So we hypothesized that this could be an effect, suggestion of the abscopal effect. Obviously, more studies are planned around this, and we're quite excited about that. Okay, toxicity. As I mentioned, our population has high toxicity rates from treatment. They're more radiosensitive. The antiretroviral therapy and the HIV status means that they have a higher chance of adverse reactions from cisplatin. So we monitored all of this very closely. We had grade 1 adipose burns in 9.5% of our patients, but this was not associated with their BMI. In a multivariate analysis, it was also not associated with HIV status or the energy put into the patients. Okay, there were no other differences in toxicities between the treatment groups. Okay. So to conclude, our results for local disease control have been accepted for publication in PLOS ONE, so you can read all about that in detail. It's quite a long paper. We explain all the challenges that we had, and that shows a significant improvement in the patients who received hypothermia at 6 months. Our early results show an improvement in 3-year disease-free survival, as well as 2-year disease-free survival. And as I mentioned, we're looking forward to the analysis on the abscopal effect. Okay. As I said, we will be following the patients for a further 5 years. We're designing further trials to evaluate hypothermia in our situation, taking everything we've learned here into account. And we're designing trials on immunotherapies with hypothermia in our facilities. That picture is our entire radiation oncology nursing team. That's our radiation therapists, as well as our oncology nurses and technicians. So it's a very small team. You can see the bed shares the room with the brachytherapy device for prostate cancer. It's a very new device donated to us, but in 5 years it's only been used 6 times because we don't have the skills to administer it. We see about 800 gynae patients in our department, and these are the staff who deal with those patients. We have 2 radiation oncologists to handle the workload, and that's just gynae oncology. We have head and neck, gastric, everything else. So it really is a challenging situation, and I thank all my colleagues from radiation oncology and nuclear medicine who've worked tirelessly to help us, and most importantly, the patients who live in severe socio-economic situations, and they fight fiercely. And finally, I'd like to thank you all for listening, and also to thank AirShow for the privilege of the award yesterday, and of presenting my results here. Thank you very much.
Minnaar.
Thank you.
First of all, let me congratulate you for carrying out the studies, especially in Africa where you have so much problems and so much constraints. So that's great. So I'm sure there would be some questions.
Did you use a PET in the beginning for staging? Probably no.
No.
But you mentioned that extrapelvic lymph nodes better respond. So you have, in some cases, lymph nodes in the aorta, para-aortal or something like this.
Yeah.
And you finally find it out with the first PET after 6 months.
Oh, no, sorry. We saw the first PETs before treatment, but
okay, that was my question.
Yeah, we didn't change the staging.
And lymph node lymph node infiltration extrapelvic was no contraindication for your study, is it so?
No, because we weren't doing PET CTs to do the staging. So if they were staged only clinically, we wouldn't have known about it. We did exclude patients who on the pre-treatment PET study had visceral disease, such as brain and bone, which we wouldn't have picked up otherwise, because ethically they had to have their protocol changed. But we kept the lymph node, extrapelvic lymph node patients.
Is included in the study?
Yes.
Okay.
We also...
And how many % of your patients had some lymph node in the pelvic region or outside? How many %?
54 in each group.
54%?
Yeah.
So a large
More than half,
number.
yeah.
Okay.
Yeah.
Okay, thank you very much. And I'm sure that there will be many more queries. And may I just request that since we have to move on.
Yes, sure. Thank you very much.
Thank you.